Right. Thank you very much, Lorenzo. That was a great presentation. And I think radiation and contrast is one of those things that we tend to forget about. But we're very fortunate to have 3 women interventional cardiologists in our panel, Dr. Velakapudi, Kearney, and Hall. And just curious on your thoughts, since all of you are young, are you concerned about it, having babies? What are your thoughts and what do you do about it? Maybe Puna, maybe you want to take it to start?
Yeah, sure. So to be honest, I had both my kids before my cardiology fellowship. I planned it well, I think. But just as an FIT and as an early career, I know, and having interacted with a lot of women who've been through pregnancies during, their cath rotations and stuff. And I think it is important. There was not a lot of information out there for women, particularly a couple of years ago. But I think the amount of information and, the orientation for women has increased a lot. It is really important to know how much radiation is acceptable. I have not heard of any issues with women having any issues with their childbirth when they've used radiation protection as it was recommended. And I think it should be a part of every cardiology orientation and every cath lab orientation before women actually get into these rotations.
Yeah, I guess just to reiterate that we actually have 2 pregnant interventional fellows at the moment, but in kind of preparation for having more women in the lab and coming into our fellowship, we were looking at folks, including Dr. Lombardi, who's here on the panel wearing a fetal badge actually. And so we've been tracking that because we want to actually have some data of people doing high volume cases, CTOs, like high radiation exposure issues, where you're not modifying your behavior and we're not even wearing double lead or anything like that. And so far, I think the results have been really promising. And so like anecdotally, everyone says that they don't have any issues in terms of their under lead exposure. And so just emphasizing good radiation practice for everyone in your entire lab, including the staff, and just emphasizing that seems to be good enough. So I think it's one of those things that people ask about a lot that I wasn't very cognizant of in a career choice, but kind of going through, a lot of women have asked about it, and there really isn't any data that we need to be worried. So.
Yeah, our data is, the fetal badges study that we did, there was no radiation exposure to the fetus badges for all of us that wore them. And as I said, our current high-risk fellow, Amy Cheney, is pregnant during her high-risk fellowship, and our first-year interventional fellow is also pregnant. And they're working, other than having to deal with morning sickness, which actually is probably a bigger issue than the radiation. Everybody's doing great. And I think, that again, in a male-dominated specialty, it's unfortunate that there are sort of made-up mythos about what's good and bad for people. And I would just say for any woman out there, if you want to be an interventional cardiologist, there's no reason not to.
Absolutely. Alison, you have any thoughts on this? I know since you're the third woman on the panel.
So I would tend to echo the thoughts of Dr. Lombardi in the sense that this didn't come up as a particular consideration for me as I contemplated interventional cardiology. I just essentially was thinking I'm going to be going ahead with it regardless. And I think it's important, as Kate said, to continue to get some actual ongoing evidence in this area as we get more women in our cath labs. At my lab, for instance, I'm the first female interventional cardiologist, so there hasn't really been a lot of specific measures in place in that regard, other than what they do essentially for our X-ray techs, et cetera. So that's essentially what we would apply. But I have not had any children yet, so.
Great, looks like it's safe. Dan, any thoughts from Penn? I know that you are very sensitive to these issues.
Yeah, so we've done, thanks Manos, and great presentation. We've done a lot of work on this and multiple ways to reduce radiation exposure, as you heard about in the presentation. One of the more important ones is just dropping the input dose and working on low dose fluoro. We work on 4 frames per second, and it turns out with a little bit of practice, you can do almost everything on that. So I think that education around this, tableside controls, what you can reduce, collimating, all of those standard principles, they sometimes get lost in the excitement of a complex case or a long case. And I think, if you really work on those, we've had very good success in reducing radiation and written some stuff about it.
Wonderful, thank you. And then maybe switch to the contrast a little bit. Mauricio, I know you do a lot of complex cases, both in the coronary, but also the structural field with people who are very old and have multiple comorbidities. Any thoughts about contrast and ways you use to handle that? And I think you're still muted over there if you want to unmute.
I'm unmuted now. So yes, we are very cognizant about the problems with contrast. So we have a few initiatives. So in every single case, we read out loud during timeout the maximum allowable contrast dose, which goes anywhere between a formula that was published in the Sky Best Cath Lab Practices, which is a GFR by 3.7 that was published before. But in patients that are really at risk of going in dialysis with diabetes and very low renal function, we try not to go above the GFR. Use the same volume of contrast as their actual GFR. We use we have a biplane room where we can do procedures and get 2 shots for the same amount of contrast. And then to prevent, we hydrate patients, and then we also measure the LVEDP just to make sure that patients are not dehydrated and titrate the hydration according to that.
Wonderful. Thank you very much. Thank you, Mauricio, and thank you for everyone for their thoughts.